This screencast is going to talk through pain theory and beliefs, and just give a brief introduction to what pain is and the beliefs that sit around pain. Thinking about what our current views of pain are, thinking about historical views of pain and where those theories have developed from. Thinking about the role of the brain in the pain experience and how this is linked with neurophysiological processes. Thinking about what develops a pain condition into a chronic pain condition and what are the differences that sit within that, and have an awareness of the treatment and potential management strategies that we can use to treat pain. So what is pain? I want you to pause the presentation here and the screencast here and spend a couple of minutes thinking about what you think pain is and what your understanding of pain is. I don't want you to Google anything or look anything up. I want you to write your own short definition of what you think or believe pain to be. And then what we'll do is we can refer back to this as we go through the screencast today. So again, just take a pause here, and then we'll refer back to that sort of later within the screencast. So with the history of pain, we're starting with the theory that was proposed by Aristotle. And that was, he proposed that pain itself wasn't a sensation, but it was more an emotion. So he didn't accept that pain was something that you could feel, but it was something that was controlled intrinsically within the body itself. And then there was some suggestion from Descartes, who developed the view from a Cartesian point of view of pain, and then started to put together the fact that pain was a felt sensation. And Descartes suggested that. So as you can see from the image that's shown on the screen, you've got this image here that shows the heat source here. So what they suggested was that there was an activation and a recognition of heat on the skin, and that the point at which the heat was being felt was attached to the brain via a really fine thread. And then this connected to a part of the brain where the stimulus, so the heat source in this case, opened a valve in the brain. And then this allowed animal spirits to flow into the muscles, causing them to flinch away from the stimulus, and also to turn the head and eyes towards the affected body part. And that's shown here. So the person's looking towards the affected body part, and then therefore move their hand or body part and turn away from the heat source protectively. Now, these theories of pain relied on the major assumption, really, that there is a one-to-one ratio of the amount of pain reported and the amount of tissue damage that would be sustained, and that the experiences of the body and mind are completely separate when pain is encountered. So the early views of pain focused solely on biological and physical causes of disease and disability, and failed really to be able to bring into account what was happening within the brain and what effect the brain could have on pain. So this was a really purist view in relation to the biomedical model. And these sit around a theory called the specificity theory of pain. And it's worth at this point having a look at the specificity theory of pain and just making some couple of lines of notes around what Aristotle said and around what Descartes said. Okay, so have a look at these images on the page. So you can see obviously that there are 3 separate images depicting some degree of hurt or some degree of tissue damage or some degree of pain. Now, what I want you to think about is, how does your current view or understanding of pain make you feel when you see the following images? So again, pause the presentation here and see whether or not you can apply your theory of pain that you've written down to these 3 images. Does it fit? Can all of the above be attributed to your feelings of pain or your feelings of hurt? So This is a really good YouTube link. So this is by Professor Lorimer Moseley, and this is a really useful link. And Lorimer Moseley does a whole series of talks and podcasts around pain, and he's seen as a leading professional within the pain circles and within the pain circuits. So do take the time to have a look at the YouTube clip that's shown here. So it's quite a long clip. It sits at around about sort of 50 minutes long. So it might be worth just grabbing a cup of tea or a drink at this point and just have it on in the background, and just have a think about what Lorimer is saying around pain, and make some notes from it. So let's start off with physiology. So a young man who's grown up walking in the outback in Australia, he wakes up one morning whilst on a camping trip and he goes for a swim. As he's walking on the river, he feels a sharp scratch on the outside of his leg. What is going on physiologically here? So use the information within Lorimer Moseley's talk, and also do a bit of reading around physiological response to pain, and come up with your own ideas about what's happening in relation to this case study here. So this is what's actually happening. So the initial contact with the skin stimulates mechanoreceptors within the skin itself. So once you have a sensation, sort of a touch sensation or a pressure sensation, an action potential is triggered along the path of the A beta fibers, and these are the first order neurons. These are fast conducting, heavily myelinated nerve fibers. And the signal then travels up his leg at around 70 meters per second. It enters the spinal cord via the dorsal root and then ascends via the dorsal column up into the medulla. The signal decussates and then synapses with a second order neuron and then travels across to the thalamus. So thinking back to what we know about the thalamus and thinking back to what we know about the medulla, start trying to make those links between pain theory and what is going on within the brain itself. Worth noting here are things such as fast conduction comes from myelinated nerve fibers. So anything that's myelinated is going to move much quicker. Thinking about how fast that signal is traveling, so 70 meters per second. And then thinking about where it's synapsing. So synapsing in the medulla and synapsing across up to the thalamus. So once the once the pain signal has reached the thalamus, this becomes your relay station. So thinking about what the brain needs to do to relay back down to the area that's feeling this sensation. Another synapse is made with a third order neuron, and then this is relayed to the somatosensory cortex. So the man now becomes aware that something has come into contact with his leg. Something's touching it. Doesn't quite know whether or not it's painful yet, doesn't know whether or not it's stinging. There's no sensation associated with that, but there is an awareness that there is something that has come into contact with the leg at this point. So if the body, the stimulus is noxious, and it's noxious enough to stimulate a nociceptor, the nociceptors are the danger sensors that sit within the skin themselves. So what you get at that point, so something that's going to cause a pain or a scratch or a stinging sensation, then you get an action potential triggered along the A delta fibers and the C fibers. Now the A delta fibers are lightly myelinated and the C fibers are unmyelinated. So in comparison to the A beta fibers that we've talked about previously, that were heavily myelinated, you end up with an action potential and a response that travels at a much slower rate to the A beta fibers that we had previously. So you ended up with something traveling at between 12 and 32 meters per second. At this point, neurotransmitters are released within the spinal cord, and the message starts to travel up the spinal cord itself. The thalamus then interprets this as the most important incoming message to the brain, and the message is then sent on to the cortex. Primary motor cortex and the precentral gyrus, which is responsible for the motor map. And then you've got, and that's shown in pink just here, so this is the motor side. And then you have the sensory map, and this sits within the post-central gyrus. And as you can see, the knee, the lower limb sits sort of closer to the central gyrus. And then as you move away, you get sort of upper limb and then down towards the face and then down sort of into tongue and internal aspects. So around about here, so in the post-central gyrus, quite close to the central cortex, is now going to become aware that there has been a sensation. Something is going on here that's dangerous and it's touched the leg, so quite close here to the central cortex. Now this is where things start to change, and this is where the map of what is going on within the brain itself becomes quite interesting. After receiving all of the information, the brain, and this is involuntary, so it's outside of our control, and this happens extremely quickly, starts to evaluate the level of danger within the current situation that the person is in, using a variety of internal and external samples or experiences. So what the brain will do is it will analyse past experience. Have we been in this experience before? Knowledge, things that we may know or may have learnt, any beliefs or cultural beliefs, past successful behaviours that have been observed in others. So what have we seen from other people? And then it creates an output. So the output will be that there is an altered behaviour or an altered physiology. And then this has an impact on the environment or on the tissue itself that's been affected. So some of the questions that might be asked or might be asked within the brain itself is, what environment am I currently in? Is it a dangerous environment? Is it something that I could have hurt myself in? What activity am I doing at the moment? Is it an activity I've done before? Is this an expected response to what I'm doing? Have I been here before? Have I experienced this sensation or this touch on my leg before? Is this similar to something that potentially I may have experienced previously? What happened last time I experienced this input in this environment? So if he was swimming, is it the fact that a fish has brushed past his leg and actually that's not a painful experience, but you've got this touch sensation? Do you need to then start alerting other people to help? Do you need to start to send out signals to other people that you're going to need external help? And have you ever experienced others within this situation? So sometimes you have an inbuilt mechanism as to how to deal with a certain situation. And that might be because you've witnessed it, or you've been training, or you've seen similar situations play out either on TV or in real life, and then you have an inbuilt response to how to deal with that current situation. So within that split seconds, the brain will conclude that there is no danger. I've experienced this sensation before within this environment. I've done this activity before and I've had it, and there's no threat to my survival at all. And therefore, as a result, the brain chooses or elects not to make that individual's leg hurt. Therefore, this model of pain being an altered output from the brain according to input from the body tissues, the environment and the brain itself, is known as the mature organism model. And this was proposed by Gifford in 1998. And the theory of this really is that we draw on past experiences and knowledge that then affects our response to given painful scenarios or given pressure scenarios where something has affected us from our environment. So remember, based on this theory, the brain has chosen not to make this individual's leg hurt. So currently this patient's not in pain. However, this guy wakes up 3 days later after his scratch, and he wakes up in hospital. He's been bitten by a venomous snake. So a year later, the man's walking in the outback again when he feels a sharp scratch on the outside of his leg. The physiology is exactly the same. He's had exactly the same physiology as what he had previously a year before, whereby his brain chose to tell him that he didn't have pain. This time he screams out and he's in absolute agony, and he screams out in pain. He looks and realises that the scratch itself was caused by a twig. Therefore, why did it hurt him so much this time around? Here what you have is you have an example of the same situation happening. So you have experienced a sensation. It's been affected in the exact same way. Your brain synapses and receives that information through the cortex. And your body then and your brain starts to sample itself again based on past experiences, based on your knowledge, based on past successful behaviours. Now, this time you've had an experience and a knowledge whereby there has been a danger and a threat to life. Now the brain recognises that perhaps this similar experience actually could be really dangerous, and your brain starts to wonder where this fits in terms of threat to life, threat to tissue. Therefore, you get a pain response because your body has experienced a similar situation that could have been a threat to life or a threat to tissue, and therefore, based on past experiences, your brain is now trying to work out what it needs to do, and therefore you end up with a pain response. So, pain in context. So, Moseley and Arntz in 2007 conducted a study investigating the role of visual cues on pain provocation. Participants touched with a 20 degrees Celsius aluminium probe and were then shown either a red light or a blue light. They were told that there were two different probes of differing temperature. When the red light was shown, the stimulus was rated as hotter, and the pain was more unpleasant than when the blue light was shown. Therefore, when a stimulus was cued as being hot, the pain was perceived as more unpleasant. Why might this be the case? What I want you to do at this point is have a think about your original description of what pain is. Have a think about what we've talked about in terms of physiology. And then I want you to start to change and affect your definition of pain based on what you've learned so far. So pause the presentation at this point, and then we'll come back to it and get on with the next part. So, the sensation of hot and cold on the skin can be difficult to distinguish. But from what we know and what we've previously experienced, we know that hot things tend to be really dangerous and cause significant damage, and that cold things tend to be less dangerous and not cause as much tissue damage. Therefore, they pose very different threats to ourselves and our bodies, and the brain therefore produces different responses. So think back to what the brain recognises and experience says between pain experiences between hot and cold. So therefore, you get a different response each time. So have a think now. So consider what you've just heard and take a look at these images in a different context. Does your impression differ when you accept the top-down view of pain and understand it as an output from the brain? Again, pause the presentation here and just have a think about that. Think about the viewpoints. So this is a really nice diagram that shows pain levels and healing times. So pain, obviously, we need to be able to link that to healing processes for bone, soft tissue, tendon, any other tissues that sit within the body. How long does that healing process normally take? And thinking about the stages of healing. So at this point, you want to start to link in your knowledge around healing times and start to bring that into your knowledge around pain. So as you can see here, you've got a moment that an injury occurs. And then you've got along the bottom how long that takes to heal. That could be days, that could be weeks. And then you've got a pain level. So initially, when you sort of hurt yourself, your pain shoots up. Your pain levels are going to increase quite significantly, and you're sitting at the forefront of the bleeding and inflammation phase of healing. And then as you reach that peak of pain or healing, then you're starting to get some scarring, some remodeling of those tissues. Your body's starting to repair itself. It's starting to lay down new collagen, and the pain itself then starts to taper off. So as you can see here, pain that's associated with tissues, you're going to get a pain stimulus, it's going to peak, it's going to get better, it's going to reduce over time. If you have pain associated with the nervous system, then what can happen is you get a peak of pain, it improves, it gets worse, it improves, it gets worse. And there doesn't really seem to be a time at which the pain starts to improve. So therefore, when we're treating patients and we're ending up with this association with pain within the nervous system, somebody's pain levels are at their peak. When they remain at their peak, they have very little relief from their peak. And this is really important when we're dealing with patients that potentially have some link to the nervous system, or potentially they're entering into a chronic phase of pain. And this is sometimes how our chronic pain patients start to present with this constant high levels of pain that they never really get a relief from. So when we're thinking about pain, we're starting to think about the red flag side of things. So we need to be really careful, really, when we're thinking about somebody's experience of pain. It's very easy to brush somebody's pain experience off as being something that they're struggling to deal with or struggling to manage. What we need to be careful of is with our subjective assessment is making sure that we're clearing out things like red flags. So have they had any previous investigations? Have they had x-rays, ultrasound scans, MRI scans that are going to help us to piece together what's going on from a pain perspective? What is their history of present condition? How have they hurt themselves? Has there been a direct history of a trauma? Has there been a direct history of a specific injury to an area that can give us an indication that actually we would expect to be experiencing pain at this point? Is it a reactive condition? So is it something that's been overloaded? Has the patient been doing something repetitively that's going to cause some inflammation or irritation of some of the structures that sit around either tendons or ligaments, etc.? Does the patient have an underlying inflammatory condition that's poorly controlled, or they're in the middle of a flare off? So thinking about your rheumatoid arthritis, ankylosing spondylitis, thinking about whether or not they've had an acute infection, because sometimes all those aspects can add up to there being an inflammatory issue, which can cause pain. What's the patient's past medical history? What other comorbidities does the patient have? Have they experienced similar pain symptoms previously? Are they experiencing pain anywhere else in their body? Is it the fact that they already have a degree of pain within their system and their body just can't deal with an additional level of pain? Have we ruled out red flags? So are there any easing factors to the pain? Is the pain waking the patient at night? Is it an unremitting pain? What makes it worse? What makes it better? Is there a pattern to the pain? Is it worse on a morning compared to on an evening? These are going to start to build up our indications of what's happening with that pain process and what's the story for this patient behind pain. What we're wanting to rule out is anything sinister, so anything that sits there that might be causing pain, such as cancers or infected joints, anything that's going to need immediate medical attention. And then thinking about what might be causing significant pain, such as your sort of cauda equina symptoms, when you're thinking about the lower spinal cord. Is there anything that's acting as a masquerader? So something that potentially is masking the reason for pain. So think about referred pain here. So a classic example is people that get pain down the back of their legs, and these would classically be deemed as sciatic patients, and people often go on and treat knee pain or ankle pain, when actually the initial pain or the pain process is actually occurring in the back. So we're thinking about where the dermatomes and myotomes are sitting, and where the referred pain or where the referral of pain is coming from. Okay, so we're going to go on to talk about pain modulation, and we're going to talk about ascending inhibition and descending inhibition. So what I would like you to do is make notes on each of these. So go through these nice and steadily. They're not the easiest concepts to try and get your head around. But if you do get your head around it, then it's really useful for patients to be able to understand where pain is coming from, and also helps you to start to link how you might treat pain. So we'll start with the ascending inhibition, so something like the pain gate theory. So let's start with something like a head bump. So a stimulus acts on a nociceptor. The action potential travels to the spinal cord, and then you experience pain. So you rub over the area that's uncomfortable, and then you're starting to stimulate through touch the A beta fibers. By doing so, you're stimulating the interneuron, and this inhibits the second order nociceptor. So go back to thinking about the unmyelinated versus myelinated fibers. So because you've stimulated the A beta fibres, remember that they're the heavily myelinated fibres, and they travel much faster. So what happens is the A beta fibres are stimulated by touch. This inhibits the second order nociceptor, so it is inhibiting the C fibres in relation to pain, and it's closing the pain gate. So not as many of the C fibres can be registered within the thalamus, and therefore the A beta and the touch is registered instead, and therefore transmission of pain to the brain is then reduced. So pause here, go back over that if you need to, and make your own notes about the pain gate theory. So descending inhibition. So descending inhibition is from the cortex itself. And this is a survival mechanism that inhibits the pain pathway. It directly involves the hypothalamus, periaqueductal grey matter, so the PAGM, and also the spinal cord. And it's been shown that electrical stimulation at the PAGM can make animals insensitive to pain. So it's a really clever and strong response. If that we can stimulate the PAGM, then we can really dampen down that response to pain. The signal descends down the cord to the inhibitory interneuron, and therefore it inhibits transmission from the second order nociceptor, and it can cause release of endogenous opioids. Now, thinking about opioids are what we use to treat pain, so we can utilize our own body's response through the use of opioids, naturally released opioids, to help modulate pain responses. So this is just an example via a picture. So you've got your nociceptor that's registering pain, and your descending inhibitory neuron is utilizing something such as the endogenous opioid to put out that pain, to dampen down that pain, to stop that pain from registering from the nociceptor itself. So again, I want you to pause the presentation here. Think about what changes we see during acute stress in relation to the following body tissues and systems. So make some short notes about the motor system, the endocrine system, cardiovascular respiratory system, what happens with sleep and what happens with the skin. Keep it nice and basic, and then have a think about what happens, and have you got any experience of having experienced severe pain, and what physiological responses you might have experienced in those 5 systems listed above. So the fight or flight response. So this is stimulated by the sympathetic nervous system. So we're thinking about the sympathetic nervous system, whereby you get an increase in cell metabolism. So you're going to have an energy store that's available to you through that fight or flight response. Dilates the bronchioles. So by dilating the bronchioles, you're getting more oxygen to the muscles because you're getting more gaseous exchange. Thinking about an increase in heart rate and an increase in the force of contraction of the heart itself. You're going to get vasoconstriction. So vasoconstriction of the blood vessels, meaning that you're liberating glucose. You're going to end up with more glucose at your disposal, so that you can then utilize that fuel to be able to turn it into a response that you're going to need quickly. You're going to decrease the activity within your gut and within the sexual organs as part of the response. You're not going to want the gut working as hard as what it does normally, because you want to have those that energy available to you in your limbs, so you can either fight or flight, run away from whatever it is that's causing you distress. So peripheral and central sensitization. So initial phase of sensitization following an injury is completely normal. This is called primary hyperalgesia. Sensitization only becomes problematic when it persists beyond normal tissue healing timescales. So again, at this point, you want to be thinking about your normal tissue healing timescales so that you're aware as to what would be a normal pain response. Experiencing pain is completely normal physiological basic reaction for humans to experience. But if it's extending and it's affecting quality of life, it's affecting somebody's ability to sleep, it's affecting their day-to-day functions for longer than is normal, then this is therefore a problematic sensitization response. So what can we do to approach this and treat the patient? So we can promote exercise, we can promote using thermotherapy, we can promote the pain toolkit. Now, the pain toolkit is a really good device that is utilised with patients, and it looks at patients taking ownership of their own pain. So thinking about what makes their pain worse, what can they do that stops them being in pain, what do they enjoy doing, and starts to move away from the patient being all consumed by pain, and move away from them not being able to function effectively, and move away from the idea that actually pain is stopping them from being who they used to be, and actually that they can continue to do what they were doing prior to being in pain. Then they just need to make sure that the hurt doesn't always. We can look at potentially manual therapy techniques, so thinking about the Maitland gradings, using grade 1 or 2 for pain responses, and also things like psychotherapy and talking therapy, which can really help patients to be able to understand their pain response, and having a direct effect on the brain can have a good influence on the physical aspects and physiological responses to pain. Now, this is the fear avoidance model, and this was modified by Vlayen and Crombez in 1999. And what's happening here is somebody who has an initial injury, and they experience the pain, and then what happens is they end up in this cycle of fear avoidance. Their pain experience leads to catastrophizing. This is the worst thing that could have happened to me. This, I'm not going to be able to do anything again. And then they enter into this fear cycle. So there's a fear of re-injury. So therefore they avoid doing that movement. So a really classic example would be somebody bending down to pick up something off the floor and end up with back pain. Therefore, their pain becomes catastrophic. They don't move as much anymore. They avoid flexion of the lower back. They then don't do things that they used to do. So their job might involve lumbar flexion. Their hobbies might involve lumbar flexion, and therefore they stop doing that. And therefore the tissues themselves don't heal effectively. They don't maintain strength. They don't have the ability then to heal as well as what they should be doing, and they continue in this cycle of pain experience. And at this point here, you get previous interactions potentially. So being affected negatively by anxiety, perhaps, or by a lack of information that's been given to them, or inappropriate information that's been given to them, or a previous physio-patient interaction that potentially didn't really affect them or have the desired effect, on the patient. And this is where the therapeutic relationship comes in. Because if we can change a patient's information that's available to them, then we can change the catastrophizing of the patient. And then we can start to change their fear of re-injury. And we can start to get them to do some movement. So we're changing the avoidance, we're changing this cycle here. And actually we then start to move out of this cycle and down into the lack of fear. So we're removing that fearful movement. And that's what rehabilitation sits within. We're getting the patient to confront their fears and confronting that movement patterning, and therefore we're going to lead to recovery up here. Manual therapy. So there was a review article done by Vygotsky and Bruns, and this is the role of the descending modulation manual therapy and then its analgesic implications. This is a really good review article for you to have a look at if you want to gain some more depth around pain and pain processes. All types of manual therapy have been shown to elicit a neurophysiological response that's associated with the descending pain modulation circuit. Now, as you go through your careers and as you go through your student careers, you'll notice that there is two very specific camps within MSK. You have the manual therapy camp and you have the people that don't believe in manual therapy. Now, in terms of manual therapy having an effect on movement, on stiffness, then you'll find people that will argue either way. Now, by doing manual therapy, are we just implementing the pain gate theory? So by pressing on a structure or by massaging a structure, are we just activating our RA beta fibers and then therefore inhibiting our C fibers? That's up to you to make that decision. So have a think about what we do in terms of treatment as physios, and then link that back to the ascending and descending pathways for pain modulation. So exercise. So exercise can induce hypoalgesia, and exercise-induced hypoalgesia mechanisms are really poorly understood. The results mainly come from animal research and suggest that there's some opioid and non-opioid mechanisms at play. So cannabinoid is a system, and it's a system that's composed of endogenous lipid-based retrograde neurotransmitters that bind to cannabinoid receptors. And then cannabinoid receptor proteins are expressed through the central nervous system and through the peripheral nervous system. Now, endocannabinoid levels are directly linked to reductions in pain, and endocannabinoid levels in circulation are significantly increased following isometric exercise. So we don't fully know how the endocannabinoid system is working, but we do know that the introduction of endocannabinoids into the person's circulation itself does have a direct effect on lowering patients' pain. So therefore, there's some discussions around at the minute in relation to CBD oils, and people have anecdotal evidence that CBD oils are effective in pain reduction. But we also get the exercise-induced side of this, whereby the endocannabinoid levels are at such that we're actually getting a reduction in pain through exercise. This paper, so the evidence for direct relationship between cognitive and physical change during an education intervention in people with low back pain, again conducted by Lorimer Moseley, was a quasi-experimental design of 121 participants. And they participated in 3-hour one-to-one education sessions delivered to reconcept. The outcome in the physical measures taken pre and post education sessions, and the results showed a strong association between changes in attitudes towards pain and physical performance. There's also found to be the change in cognition accounted for 77 and 60% change in variance in a straight leg raise and a forward bend retrospectively. Pain education tended to result in improved physical performance measures, although it's not displayed statistically, and the statistics weren't statistically significant at this point. So then we go back to our old friend, the biopsychosocial model, looking at the biological, the psychological, and the social aspects, and what impact they therefore have on pain. So the Keele University developed the StartBack tool. Now, StartBack at the minute in outpatient departments as a sort of predisposition to how well somebody will do post back pain injury. So it's worth having a look up the StartBack tool. It's a questionnaire that can be given to patients, and it identifies themes surrounding the patient's conceptions of their own journey with their own pain. So again, have a look at the StartBack tool. It's a useful one to use within your own practice, and might be a useful one to sort of have a look at if and when you go out on placement. So this table outlines some of the messages from patients to healthcare professionals that had lower back pain. And some of the aspects that of note really are the ones that we've starred. So they found it unhelpful when we don't listen to them, when we give them scary information or information that they don't necessarily understand, or when we overtreat them unnecessarily. They found it helpful though when we care and take time to listen to the patient concerns and fears. Explain why we have pain using simple language. A lot of the things that we've gone over today within this screencast can feel quite overwhelming for patients. It'll feel quite overwhelming for you as well. So think about how you can make pain easy to explain to patients in basic language. They like it when we reassure them and build their confidence, and also make them feel safe. So thinking about your rehabilitation, you're trying to make patients understand that normal movement is good movement, and that actually we do want them to move structures, because that's what's going to help them heal and remodel. So here's just an example of a case study. So you've got a 60-year-old female who's had a left bimalleolar fracture after a fall. They were treated with an ORIF and a plaster of Paris. They were non-weight bearing for 6 weeks, and they're referred to outpatient physio now the cast is removed. After the plaster of Paris was removed, an x-ray was taken, and it shows really good callus formation of the bone, so it's healing really nicely. They're now fully weight bearing as tolerated. But the patient's really reluctant to weight bear, and is worried that they will refracture. They don't even like touching the area or looking at the area. Now, this is really common for people that come out of cast, because the area can look very different. It can look withered, it can look red sometimes. There can be quite a lot of flaky skin. There can be some wasting of the muscle tissue. So thinking about this case study, how would you approach this patient's management, and why? So think about the mechanisms that we've talked about. Think about the management strategies that we've talked about, and have a think about what plan you would come up for her. So having completed the session, write another definition of pain. Don't look at what you wrote earlier. And then once you've written something down, compare them. Are they very different? Are your viewpoints very different at the beginning compared to at the end? Are you surprised by your viewpoints on pain? Is there more that you wanted to learn about pain? And at this point, it might be worth making some notes about some areas that you might want to look into in more depth. There's so much wealth of knowledge out there about pain. And you can do whole master's modules on pain. So this is just a really basic overview. And I don't expect you to understand it fully, but I expect you to understand some of the concepts. So in conclusion, pain is complicated. It's not an output and an input. Remember to check your red flags and your masqueraders. Educate your patients. They understand more than what we give them credit for, and they want to understand, they want to learn, they want to understand what is going on with their body. Be careful what you say. Be careful about certain words that you use. There's always stories of doctors and healthcare professionals using words that patients cling on to. So things like slipped discs, things like disc damage, hurt, harm. Those are all words that patients will cling on to. So making sure that you're educating your patient that wear and tear within the lower back or within any structure is completely normal, and that hurt doesn't always mean harm for a patient, and that you can have healing properties, and you can have healing, and you can use normal movement to help with pain processes. And make sure you're moving towards a biopsychosocial approach and not just focusing on the biomedical model. Here's a list of some useful references and quick links. I would really encourage you to have a look at the pain toolkit. It's a really useful toolkit that can be used with patients. Thank you for listening.